Deshi Gile Kushi Hobo.
Thank you.
Nice to be back here. So, in the topic that I'm assigned today, which is getting the best from heart team for coronary revascularization, I'm actually quite curious to understand how the heart team concept has been established in Bangladesh. To start out with this presentation, let's just go to a case example. This is a 64-year-old gentleman with diabetes, with hypertension, with smoking, with chronic renal impairment, had a previous history of PCI 3 years ago, admitted for recurrent end-STEMI heart failure, EF of 35%, NT-proBNP of 1,800. So if you look at the anatomy here, we have a very tight osteocircumflex stenosis. We have a left main that is also diseased. We have also a right coronary ectatic arteries. So the question here is with a syntax score of 29, and you have a syntax 2 or PCI 4-year mortality of 27% versus CABG 4-year mortality of 12%, what are you going to do as a cardiologist taking care of this patient? So the development of a heart team is actually not a novel concept. In fact, way back from the 1970s when Andre Gruentzig first performed his angioplasty, he was actually discussing with his surgical colleagues very closely in Zurich in deciding which is the best treatment strategies for the patients. And so as a result, there was already a close relationship between the two specialties of cardiology and cardiac surgery. Subsequently, when we look at some of the early trials of coronary balloon angioplasty versus bypass surgery in the Bari trial in the 80s, to the East trial in the 90s, to the MAS2 trial in the late 90s, we find that all these trials actually were involving coronary heart team in the decision-making process. In fact, AHA way back in 1995 has already recommended that a multidisciplinary team be set up to evaluate patients with severe heart failure. So the heart team concept is not a new one. However, it was only in the 2003 to 2007 period when syntax trial was first carried out that the heart team becomes more prominent and become better known to everybody. So we know from the syntax trial that it was a comparison between PCI versus CABG. And in the heart team, patients were actually enrolled either in the randomized study or actually in the respective registry. And this was all coming about because of a joint decision between the members of the heart team. So what does the heart team comprise usually? The common concept here is that you usually have a clinical cardiologist, and you have an interventional cardiologist, and you have a cardiac surgeon who is looking after the patients with coronary artery disease. And who are the patients who are likely to be brought to the heart team for discussion? It is really likely going to be a complex disease, left main or multivessel coronary artery disease. And the role of the heart team here is really to take a balanced and an objective approach to deciding what is the best optimal coronary artery revascularization strategy. And in discussion in the heart team, many of these factors would have been considered, from the patient's coronary anatomy to his comorbidities, whether he's got renal failure, he's got stroke before, or whether he's got porcelain aorta, which will preclude a bypass operation, or what is his age, his frailty, any chest deformities, and ultimately the patient's preference will come into considerations. Not only now do we have a heart team for multivessel disease, we actually has now extended to patients with cardiogenic shock. And so in my center, when you have a cardiogenic shock patients coming in, it is a cardiogenic shock team that will come in to assess the patient, which comprises an advanced heart failure specialist, an interventional cardiologist, a surgeon, as well as a critical ICU care specialist. So the whole idea here is to decide what is the advanced strategy, particularly with regard to revascularizations and the use of early mechanical circulatory support system. So heart team from surgeons and cardiologists has now expanded to even more people because our patients are now getting more complex. We now have patients that have lung problem that will require rheumatologists, or diabetes that requires optimal control, and we have neurologists, geriatricians, and so forth. So the heart team concept has now gone beyond just interventional cardiologists like you and myself. But what is the evidence for a heart team? Why do we need a heart team here? The trouble here is that when we decide on what is to be treated, what patient is to be treated, oftentimes there is a discrepancy between the optimal guideline recommendation and the ultimate treatment that the patient receives. There's only moderate agreement between the initial treatment decisions and the actual heart team. But we know that this dichotomy in terms of decision-making and ultimate and operator-based preferences actually improves when you have everybody sit down together for an open discussions. And what is also important is that we know that heart team decisions are oftentimes reproducible and is concordant with most of the guidelines recommendations, particularly that of the American Appropriate Use Criteria recommendation. The trouble with heart team is that we have never shown that it actually improves a patient's outcome. Most of the evidence governing the heart team concept, although it's a class 1 recommendations, was based solely on non-randomized observational studies and consensus opinion. So there are significant challenges in setting up heart team. The widespread adoption in everyday practice remains underutilized. Heart team at most, perhaps in your practice, may only apply to 11% of patients with stable coronary artery disease with complex anatomy. And there's oftentimes a treatment discordance from the heart team between the patient's physicians and ultimately the heart team guidelines recommendations. So the heart team approach really is to take everything about the patient's data, subject him to a team where there are multiple subspecialties involve the patient's family and members, and then coming to a decision in a shared decision-making process. I want to emphasize here, it's a SDM, shared decision-making process. And hopefully, this will bring about a good patient outcomes and then helps the heart team to further improve and optimize their discussion process. So the whole idea of a heart team here is to build an ecosystem here. You now have a core team, which is you and I, cardiologists, but now you also have an expanded team where you have heart failure specialists, primary care physicians, and so forth. And this will always have to be handled by a program coordinator because you will have no time to set up the heart team. And oftentimes we may have to actually go into a second level of heart team discussions involving hospital administrations even to provide financial support, administrative support, and so forth. So the key principles for an effective multidisciplinary heart team are as follows: strong team leadership, mutual respect between the team members, consistency in the workflow and team member tasks, a clear delineation of the roles of the team members, regularly scheduled case review meeting. You can't have a heart team that don't meet more than maybe once or twice a year. Regularly schedule a QI and a MMM meeting, and patient-centeredness. So the heart team now has got additional responsibility besides just providing patients a decision treatment. He has to gather team member input. He has to actually ensure effective communication. He has to review the process billing. He has to track research performance, and so on and so forth. So what constitutes a 5-star heart team? It's like a dream team of a heart team. One that adopt institutional protocol for accountability, utilizes templates and AUC scoring system as appropriate, foster diversity of opinion and consensus of recommendations, creates an official recommendations to present the patients for shared decision-making, and employs a feedback mechanism. When you have all these elements in your heart team, you are a dream team. So even during the COVID time, and the heart team actually continued to operate in many centers. It continued to provide the patients with decisions that hopefully will improve their outcome. And you find that the heart team operating mechanism actually changed. People are using less of a physical in-person meeting. You're using a Zoom meeting, for example, electronic meeting, video conferences, and so forth. Some of this still persists even though the COVID pandemic has subsided. So now the heart team, as we all know, has gone beyond just coronary disease. It's gone to structural heart disease. It's gone to pulmonary embolism. It's gone to heart transplant, obstetric, and so forth. So what is the future of heart team here? I think the future of heart team really have to involve artificial intelligence here. And so this is where you're going to gather all the big data and then predict the outcomes and the prognosis of a patient as you make the final decision. So back to our case here again. This was the original patient, triple vessel coronary artery disease. So we spoke at great length the team meet up. These were the people involved here. They actually assessed the patient's nutrition, anatomy, and so on and so forth. And it was finally decided on the multi-vessel low-volume PCI. So this patient had a circumflex fixed with a 40 cc contrast under Ivar's guidance, and 3 weeks later, 20 cc contrast to treat the RCA. So in conclusion, the heart. Thank you very much.
Thank you. Now, any